Take note, in this case, the patient's unaffected arm supports the affected arm, reducing pain. Here, the physiological position of the bones of the shoulder joint are demonstrated using an anatomical inlay. Highlighted now are the head of the humerus, the acromion, the coracoid process, and the glenoid cavity of the scapula. An animation is used to show the anteriorly dislocated head of the humerus from different angles. Take note that the head of the humerus is trapped behind the glenoid cavity of the scapula. This is typically seen in an anterior dislocation. Loss of the deltoid contour can be seen under the acromion on physical examination. Also, the prominent humeral head can be palpated anteriorly, as seen here. Based on these clinical findings, an anterior shoulder dislocation can be diagnosed. It is advised to examine the neurovascular status of the upper limb before starting the reduction. Although most injuries are caused at the time of dislocation, some may occur during the reduction. Adequate analgesia should be administered and, if required, sedation. This should be done as per local pain management protocol before positioning the patient. The patient is placed in a prone position. The affected shoulder should be freely hanging downwards in 90 degrees of forward flexion, not touching the floor. A cushion may be placed under the shoulder for adequate positioning. A sandbag may be used as an alternative. In this position, often the shoulder may reduce itself spontaneously. Relaxation of the shoulder muscles is essential for a successful reduction. Analgesia and patient comfort are therefore essential. If the shoulder is not spontaneously reduced, extra weight can be added, as shown here. In this case, a Chinese finger trap is used and some extra weight. If not available, containers of normal saline and a stockinette can be used to apply weight. Note that the weight is not touching the floor. Again, spontaneous reduction of the shoulder joint is tried. Should spontaneous reduction not be achieved, manual traction on the arm is advocated. Due to the fact that the extra weight provides continuous traction, they should be in place before attempting manual traction. Both hands are positioned proximal from the wrist joint and continuous downwards traction is exerted. Care should be taken to exert continuous downwards traction. If this is not done, the patient's muscles go into spasm. The right hand can be positioned onto the scapula to facilitate countertraction. Often these steps may be sufficient for a shoulder reduction. If not, exo-rotating the arm and scapular manipulation should be performed. First, the exo-rotation of the arm is demonstrated. The physician maintains his position and continues to exert downwards traction. His right hand is now positioned onto the elbow, with it being slightly flexed and the arm exo-rotated as shown here. Here it is shown again in one smooth movement. Note the same movement from a different point of view and after an animation is added. Note that during the exo-rotation of the arm, the head of the humerus is repositioned. A typical palpable and audible clunk can be felt and heard on reduction. With successful repositioning, the patient's pain is immediately reduced. Next, the scapular manipulation will be demonstrated. This can be used when exo-rotation of the arm is unsuccessful. The contour of the scapula is visible and is now highlighted. Scapular manipulation should be performed while downward traction is continuously exerted. The palm of the left hand of a second physician is positioned on the lateral aspect of the scapula with a thumb on the superior lateral border. The palm of the right hand is positioned around the inferior tip of the scapula with a thumb on its inferior lateral border. Pressure is then exerted medially. This way, the glenoid cavity of the scapula is moved medially, which will help to reduce the head of the humerus. All previously shown techniques can be used to reposition an anteriorly dislocated shoulder joint. The repositioned shoulder joint should always be supported after the reduction. External rotation of the shoulder joint should be avoided, especially with the arm in 90 degrees of abduction. The stability and function is tested by the physician slightly flexing, extending, and abducting the patient's shoulder joint. A sling is used post-reduction to maintain the position of the arm. Take note that post-reduction care is as per local protocol. The angle of the elbow should be less than 90 degrees, so the hand is positioned higher than the elbow to prevent swelling of the forearm and hand. It is advised to repeat the neurovascular examination in order to make a comparison to the findings prior to the reduction. If a change is noted, it can be acted on. It is advised to perform imaging studies after the reduction. This is in order to evaluate the position of the humeral head and to detect any fractures.